So good morning, everybody. My name is Riitta Kerttu-Kaltiala. I am from Finland. I am a professor of adolescent psychiatry in Tampere University in Finland and also chief adolescent psychiatrist in Department of Adolescent Psychiatry in Tampere University Hospital. In Finland, we have services for gender identity services for minors since 2011. Finland is a sparsely populated country of 5 million, roughly 5 million, a bit more, inhabitants in the northeast corner of Europe. It is a member of European Union. It is highly industrialized and technologically advanced mixed economy, which it combines a free market and a Nordic welfare state model. And we have extensive publicly funded health services divided to primary, specialist level and tertiary level services. And gender identity services include in these publicly funded health services. Tertiary level or gender identity services are regulated on a legal level so that the diagnostic assessment that may result in medical gender reassignment is in Finland centralized, nationally centralized by code of law to 2 of the 5 university hospitals, and they belong to the level of tertiary level service. Which means that people cannot self-refer to there, but they need to have a doctor's referral that needs to be assessed and accepted before they can enter these assessments. And the services, gender identity services for adults were established in 1990s and teams for minors were opened in 2011. Before 2010, gender identity problems in children and adolescents were really not discussed in Finland. It was a non-issue. It was not a discussion within the medical profession and within child and adolescent psychiatry or any field of pediatric medicine, and it was not an issue in public discussions. And the initiative to open the services for minors came from the adult side. Adult services, they had certain pressure of requests for starting assessments to people who were not yet legal adults, so were not yet 18, and political pressures and waves of political and public discussions taking place elsewhere, coming also to our distant corner of the world. So, but these services were then established. And I was given the task as the chief psychiatrist in Tampere University Hospital Department of Adolescent Psychiatry to establish one of these two services. The other is in Helsinki, as are divided the services for adults in Tampere University Hospital and Helsinki University Hospital. So diagnostic assessments that may result in proceeding to hormonal and surgical interventions take place in multidisciplinary mental health teams, and then possible hormonal interventions are initiated and balanced by pediatric endocrinology team and or hormone polyclinic if they are a bit older, and long-term hormonal care transfers to local services. And publicly funded surgeries with gender dysphoria indication are available only for legal adults by referral from the above-mentioned assessment teams. So people can also obtain further feminizing or masculinizing interventions on their, and even surgical interventions on private sector if they are willing to pay out of the pocket. But public services include chest masculinization, orchiectomy, oophorectomy, hysterectomy, and genital surgeries. 2 slides to indicate how much the referrals have increased. So this is about the child and adolescent services, and this is from a publication of ours where we compared the referrals to child and adolescent gender identity services in 4 Nordic countries and in the UK. UK is not in the same picture because the population is so much bigger that the figure didn't work. So we only have the Nordic countries where we have small populations in this figure. And here you see the referrals to adult services. And of note, the referrals to adult services mainly, over 70% of them concerns late adolescents, so people who are aged 18 to 22. And from my perspective as an adolescent psychiatrist, they actually are still in the developmental phase of late adolescence. And this is also a new development. Back in previous decades or back in the 90s, also in Finland, as has been mentioned several times in this meeting, the referrals to gender identity services of adults concerned mainly mature, middle-aged adult people with male sex. But nowadays, also in adult services, they mainly concern late adolescents with female sex. When we opened this service, we expected to see the so to say, model patients for the recently published Dutch model of care. And this has been mentioned and repeated so many times that maybe I don't repeat it, but we expected to see that kind of patients and expected to also see that the parents might be very concerned and maybe upset about the situation. And we were ready to work with that. Expected that the patients would be very few given our small population and the figures of prevalences that were then published or estimated in the literature, because real population-based epidemiological study is yet not made and maybe not possible to make in a way, as this field is changing all the time. So what would be searching in the population is a bit of a question. Anyway, what we really saw was something really different. So from the very beginning of our service, 85%, more than 85% of the young people who have contacted have been biological girls. The mean age at admission to our services has so far been 16.2 years. So you see they are in the middle adolescent developmental phase, and we have seen very few early adolescents for whom basically the Dutch model of care was introduced. And some more information about these young persons. Less than half of them have been living with both their parents, whereas in total population of the adolescents of the same age group, over 3/4 actually living in Finland together with both their parents. 2/3 of these young people had and still have over this time, these 12 years, a history of specialist level psychiatric treatment. And to obtain specialist level psychiatric treatment, you actually need to present with severe psychiatric problems, because specialist level, so secondary level psychiatric services require a doctor's referral from the primary level of services, and they are only available for severe problems. Mild mental health problems, minor difficulties in the field of mental health, life crisis, and that kind of things are expected to be treated on the primary services, such as student health, for example. So they had a history of specialist level psychiatric treatment, and the distribution of psychiatric diagnoses and the prevalence of symptoms with the symptoms which they display is actually equal to that among adolescents in psychiatric outpatient services, specialist level outpatient services in general. So the young people who started to come to our newly established gender identity services and are coming there up to date present with similar psychopathologies than adolescents who are admitted to general adolescent psychiatric outpatient services. I may show some more information about that tomorrow. And there has been in this group who's coming to these services a great overrepresentation of autism spectrum conditions, depression, anxiety disorders, and suicidal ideation, as has been reported elsewhere in similar clinics across the Western world. So immediately, as you can figure, when our patient mix was so totally different from what was described in the literature, and it was so different from whom we were preparing ourselves to work with, then we faced great challenges. It was a challenge basically for us to adjust ourselves to the idea that we would be intervening in the healthy functioning bodies of early adolescents who are yet to develop and consolidate their identity, because from our perspective, identity development is the main developmental task of adolescence, and identity consolidation is the outcome of successful adolescent development. However, when we were given this task, and I prepared by reading all the literature that was then available, and Dr. Jugar just revealed that it was not really much at that time, I thought that this is now the new knowledge, and this is what is done nowadays, and we will learn this also in Finland, so we were prepared to do the same. However, the young people were not the same, and they did not correspond to the earlier literature, and they did not correspond to the public discourse related to gender identity and gender dysphoria, because at the same time, the public discussion entered our distant corner of the world, and it was very much orientated towards that there is this new treatment model, and there is this big problem that can be treated with this approach. And then it was a bit of a stressful situation for us when we see, well, the patients are really different from what is expected in the public discussion, so that put a bit of a pressure on us. A majority of the young people who contacted our service presented with profound identity confusion. It was not only about gender identity that they were struggling with, but many had actually a very profound identity diffusion, and they were really kind of lost in asking who they are. and that was much more than just gender identity. There also started to emerge in a couple of years new identities, because firstly we were talking about identification with the opposite sex. And the whole system in Finland was based on the notion that some people feel that they really are the opposite sex, and we can help these people by aligning the body with this identity. But there started to emerge new kind of identities and new desires of increasing variety of body modifications. And then also after a while, when we had allowed some young people and had organized a proceed to hormonal treatments, we started to see that their mental health and functioning did not improve as was promised by the scientific literature of the day. And actually they often deteriorated, and we could not be convinced that it was generally in the best interest of the young people to encourage medical gender reassignment after a while, having seen all this that I shortly outlined to you. So the gender identity teams, and they had similar concerns in the other team. We are collaborating closely, but also in the adult services, because they were getting all these young adults, or actually late adolescents. So the four mental health teams together, we requested for national guidelines from a national body that is responsible for giving outlines for what services are provided in publicly funded health services in Finland. I was the one who took initiative to ask for such guidelines, but I have not been the member of this guideline committee itself. It was yesterday, somebody said so, but I was heard in the process, but the committee is organized by Ministry of Health and Welfare, and I've never been invited to be a member of it. National guidelines were then given 2020. And in a nutshell, they advocate that pre-puberty we perform no medical intervention. Psychosocial support is to be provided as appropriate, according to what kind of problems the child has. First-line treatment of gender dysphoria in minors is psychosocial intervention supporting identity exploration in local services. So this is the responsibility of any service working with children and adolescents, and whatever service is best available for this particular young person. Appropriate treatment of possible psychiatric comorbidities and management of associated needs, for example, pedagogical needs, child welfare needs, need to be met, and they have to be carried out before considering referral to gender identity units. And if considering medical gender reassignment after the first-line interventions and the possible treatment of co-occurring problems, mental health and other problems, appear appropriate and timely, a referral to the nationally centralized gender identity services can be issued. And the treatment of any associated difficulties remain in the responsibility of local services, because the gender identity services cannot take the full responsibility for all kinds of pedagogical and child welfare and maybe other mental health issues that alongside of the assessment still need treatment. And in the nationally centralized services, a very thorough multidisciplinary assessment by a team comprising child and adolescent psychiatrist, psychologist, social worker, and psychiatric nurse expert with the young person and their guardians will take place, which comprises multiple meetings over 6 to 12 months. And you can describe it by, or put it in different facets of excluding contraindications such as severe mental health issues at the moment, profound identity confusion, or totally chaotic life situation with unmet child welfare needs, or that kind of severe problems. Then it comprises gender identity in the context of identity development at large, and the developmental task of adolescents, assessing whether the developmental tasks of adolescents are progressing age appropriately. And readiness for the interventions and the changes, and appropriate referrals and follow-up. And the appropriate referrals can also be referrals to, at the moment, more timely mental health treatment somewhere else. So I don't mean that it's always referrals for hormonal treatments. And transfer to more appropriate or more timely interventions is also possible at any stage of the assessment. So if it turns out, for example, when the young person starts to meeting the psychologist that this is not really appropriate at the moment and not timely, and there are more urgent need at the moment, we terminate the assessment and refer the young person to more appropriate services. They may return later if so needed. Then we can return to the question. Possible medical interventions with minors. Medical interventions they are hormonal. So hormonal interventions are possible with minors. And in childhood onset gender dysphoria that intensifies in puberty with no severe psychiatric comorbidities and appropriate developmental support. So patients meeting the original eligibility criteria for the Dutch model published roughly 10 years ago. We may use blockers to halt pubertal development. They can be considered after early stages of puberty, so in practice from about 13. And cross-sex hormones can be considered from 16 if desired and deemed appropriate. And in adolescent onset gender dysphoria, or if the young person is already in the middle adolescence or closing to early adulthood or late adulthood, so adolescent onset gender dysphoria with most likely stable and persistent cross-gender identification and no severe psychiatric comorbidities if they have an appropriate developmental support. Cross-sex hormones can be started from age 16 and it can take place with or without wash out with blockers. That's on the courtesy of the endocrinological. Any surgeries on gender identity indication are not available in Finland for people under 18. And I think after these about 12 years of working in this field and reading and networking and doing my own research, of which I'm going to talk more about tomorrow, I think it's time to end exceptionalizing gender dysphoria. Gender dysphoria in children and adolescents has been hugely exceptionalized. And we have created a public discourse that assumes that this is something totally separate from the other aspects of life, other aspects of adult childhood and adolescent development, family dynamics, identity development, you name it, of the child and adolescent, whereas I really think that gender identity is but one facet of identity development, and it is taking place, the development, in the context of the development as a whole, and it's being influenced and is also influencing all the facets of childhood and adolescent development that normally are in interaction in the process of a young person becoming an adult. So it is, in the beginning of our services, we saw the situation that professionals fully competent in meeting pedagogical, child welfare, substance use related, mental health related, family problems related, etc. needs were totally paralyzed because they thought that gender identity is something so different, so exceptional, that the normal practices and normal ways of helping young people do not apply. But to my great pleasure, I can say that in Finland, now at the moment, the professionals have regained their competencies and everybody is doing their job, which is absolutely necessary with or without gender identity issues in the young person. We all have a gender identity anyway, and we are living in this world. An adolescent needs to complete all the normative developmental tasks of adolescent regardless of their gender identity. And I really think this is my illustration of how I understand the situation now, because I've been talking about clinical gender dysphoria and people who contact clinical services, but we also see over these years, we have seen an increasing number of adolescents who identify as transgender. And they do not all seek for treatment. And I think it's really good that young people can express their identities as they feel best suitable for them, and it's of utmost importance that the society allows them to express their identity and kind of live it out as they best feel suitable for them. But if we think about all adolescents, a share up to even in some surveys up to 9%, close to 10% already identify as transgender in one way or another. Some of them experience gender distress or gender dysphoria, and we don't know exactly how many. Then we have adolescents in psychiatric care. They are in Finland, up to 10% of all adolescents are in contact with psychiatric services. And among them, feelings of gender distress are much more prevalent than among the population in general. And the violet dot in the middle illustrates the share of adolescents who may benefit of medical gender reassignment interventions, maybe already during developmental years. So what should we do now? I think after all these experiences that meeting the psychiatric needs of gender distressed minors should be a priority because many of them present with profound and complex psychiatric comorbidities. Hormonal interventions that modify secondary sex characteristics should among minors be used with caution, preferably restricted to a context of a formal research program until evidence that meets the contemporary requirements of evidence-based medicines have been gained, and we do not have this evidence yet. And gender reassignment interventions have to be subjected to same requirements of evidence and same critical discussion as in any new medical interventions that are brought to the field. So same requirements of evidence as any new interventions in medicine. So this was what I had planned to say, and I see somebody would like to comment.